Welcome to the Nourish Child Podcast, a show about childhood nutrition, feeding kids, and dealing with the ups and downs of growing a healthy child. Here's your host, registered dietitian and childhood nutrition expert, Jill Castle.
Hey friends, I'm Jill Castle, a pediatric dietitian, mom to 4 kids, and host of this podcast. I started this podcast in 2016 as a way to help families and healthcare professionals learn more about nutrition and feeding kids. My goal has always been to make nourishing your families easier through breaking down science into understandable concepts you can put into practice right away, and shedding light on and improving the emotional well-being of kids through feeding and food. You can always go deeper on my website, thenourishchild.com, where I have resources for children ages birth through teen. I'm always so grateful you're here, and I hope you enjoy the show. Well, hello there, friends. Welcome back to the Nourish Child Podcast. I'm Jill Castle, your host, and I am talking today about the new American Academy of Pediatrics clinical practice guidelines for evaluating and treating children with very high body weight. So I've been thinking a lot about this and trying to put together a cohesive sort of rendering of how I'm feeling about these guidelines, and also sort of watching and listening to others who have made commentary on these. There are many amazing pediatricians out there, and I want to emphasize that I'm coming at my perspective with a complete appreciation for the work that pediatricians do. I'm also coming at this as a mom of 4 children, as a registered dietitian who has worked with children and their families for over 30 years in private practice, where I provided face-to-face help to these families, to many families. And thirdly, I'm coming at it as somebody who is writing a book that takes into account this situation. So my perspective is governed by a lot of these sort of filters, if you will. Now, these guidelines came out in January. It's a 100-page document. It's very dense, over 800 references that were included in this clinical practice guideline. Now, some of you might be wondering, what is a clinical practice guideline? Well, it's a statement with recommendations that are intended to optimize patient care. So we have clinical practice guidelines for all kinds of health conditions in children. We have some for food allergies, for example. There's just a variety of clinical practice guidelines. They're basically developed for healthcare practitioners to have a recommended path for evaluating and treating children with certain types of conditions. And in this clinical practice guideline, the focus is on the disease of obesity. Now, if you have been on social media, reading the papers, watching television, you've probably heard or experienced some of the emotions and opinions that have come out from these guidelines. New York Times has had articles, 60 Minutes, social media has been full of perspectives on this, blogs. Lots of people have opinions and an outpouring of their own takeaways on these guidelines. And today I'm going to jump to my take on these guidelines. So here we go. I have divided this into disappointments and concerns. So we'll start with the disappointments first. Or rather, let me backtrack and just say my overall perspective. My overall perspective is that I believe that these will uphold the stigma that is around body size, causing more harm to children, despite the hard work and good intentions I suspect and believe went into developing these guidelines. Unfortunately, we have such a strong societal stigma around size, particularly around larger body sizes. And these guidelines won't correct that, I don't think. While it aims to offer options to those who are in larger bodies and who have health conditions, it does so without changing the underlying or addressing the underlying stigma that shapes a lot of these recommendations, unfortunately. So, as I mentioned, I've divided this into disappointments and concerns, and I'm going to walk through what these are for me and what's top of mind for me. I've written these down, so if you hear me shuffling paper, it's because I'm trying to be very organized with my thoughts on this. Number one, and the biggest disappointment I have, is the continued use of the body mass index, or the BMI, as the primary screening tool for identification and treatment for these children who are identified with stigmatizing words such as overweight or obesity. It puts weight as the central determinant of a child's health. And I know that weight does not define health. It suggests that children have treatment for higher body weight, and that treatment is weight loss. Again, there's so many problems with viewing a person's body size as a determinant or indicator of their health. We know that focusing on a child's size, really whether it's a larger size or a smaller size, can lead to poor body image, poor self-esteem, weird parent interactions with children, and these can lead to children feeling unworthy. And those feelings of unworthiness can lead to behavior, psychological, and emotional problems. And what the evidence tells us is that having these behavioral, psychological, and emotional problems as a result of feeling unworthy or having low self-esteem or poor body image can lead to higher body weight, higher body fat, and can increase the risk for associated conditions like high blood pressure, for example. I call this a stigma cycle. It just gets triggered so often, I see, in children when the focus is solely on their body weight or their size. There are other tools. I call this sort of the whole child approach. When you're looking at a child, you're not just looking at one thing. You're looking at everything. You're looking at their family culture. You're looking at their health behaviors and their habits. You're looking at their social determinants of health, the environment they're growing up in that they have no control over. You're looking at other things like blood pressure and blood fats and cardiovascular function. There's so many things that tell us whether a child is healthy or not. And many of those things have nothing to do with the size of a child or their body weight. And so for me, my greatest disappointment is that I feel like these guidelines really missed an opportunity to change the language around the condition of obesity, to change the way we screen for it, to change the screening tools, and even more importantly, to take the opportunity to stand up against the stigmatizing of bodies in childhood. That's my greatest disappointment. Another disappointment is that rather than focusing on BMI or a child's size, that they did not take the opportunity to focus or prioritize conditions. So it's the conditions that are having a negative impact on a child's physical health and body functioning. So conditions like high cholesterol, high blood pressure, prediabetes, non-alcoholic fatty liver disease, asthma, obstructive sleep apnea. These are conditions, right? And while they may be associated with a higher body weight or a larger body size, they also exist in children who grow up in smaller body sizes and who grow up in mid-sized bodies too. Meaning that smaller children and children growing up in mid-sized bodies can have hypertension, high cholesterol, and a lot of these other conditions as well. So treatment doesn't mean we have to shrink a child's body size. Treatment means that we prioritize the condition and we treat that. When you have a thin person or a smaller person who has high blood pressure, they are not told to lose weight. They are treated for that high blood pressure. Weight is taken out of the equation, And I feel like we should have done that too with these clinical practice guidelines. I feel like we had the opportunity to emphasize treating conditions without bringing weight or body size into the mix. Because when you bring in a child's body size, the stigma cycle begins. What I just talked about, feeling bad about yourself, feeling unworthy, leading to behavioral, emotional, and psychological problems, which just make health conditions worse potentially, and also potentially encourage more body fat. The third area where I feel disappointed is this idea of intensive health behavior lifestyle treatment for children over 2 years of age. This lifestyle health behavioral treatment really involves food and diet, exercise, sleep, screens, lifestyle behaviors that are good for everyone, not necessarily just good for children in larger bodies, but they are good habits to establish for all children. But when they reviewed sort of studies that looked at intensive health behavior and lifestyle treatment, the outcomes are not very impressive. They're modest at best in terms of helping children take body fat off. In fact, there's hardly any improvement in BMI when undergoing these intensive lifestyle treatment and health behavioral approaches. And besides that, the parameters for conducting this kind of treatment is 26 or more hours, face-to-face, over 3 to 12 months. So you will get no pushback from me on the importance of healthy lifestyle behaviors, because these are good for every child. And as a side note, is exactly what this book I'm working on is all about. But an intensive intervention like this for many families is very costly, not only financially, but of their time as well. And with outcomes that don't seem to really have a big impact in terms of health conditions.
Kids change a lot. Their nutrition needs, eating habits, and food preferences do too. So much so, it can be hard to keep up. The Nourished Child, a website designed for parents who want more nutrition education, helps parents like you get crystal clear on raising good eaters. We've cracked the code on nourishing the whole child, whether you're raising a baby, a teen, or a child with health concerns. Our nutrition school and parent education programs help you get the inside scoop on food and nutrients, positive food parenting, and building self-motivated, autonomous kids who are good eaters. Visit thenourishedchild.com today.
Not to mention that taking a child in for intensive behavioral health and lifestyle treatment may also be stigmatizing in and of itself. My take, which has always been, and I wish that we would sort of shift to this in general, is to help the parents and the caretakers and leave the kids out of it. Help parents set up these lifestyle behaviors from an early time, or help them revise health and lifestyle behavior should they need to. But children, when we bring them into the room, we bring them into the conversation, we cannot help, even if we're not intending to stigmatize, we cannot help or prevent the stigma that goes along with singling out a child like this. BMI or body size is not an outcome of success. BMI, weight, and size are not behaviors. So when we're talking about lifestyle interventions, the focus should be on improving behavior, not on changing body size. When we bring body size into it, we are unintentionally or even intentionally creating potential stigma for children. Now, these clinical practice guidelines, as I mentioned, it's a big document. It's 100 pages long. And a big part of this document gets into more aggressive treatments for children. And I want to sort of walk through that with you. And so again, pharmaceuticals for children over 12 years of age, but they also say in this document that children between 8 and 11 years of age are okay to have pharmaceuticals, drugs, in conjunction with intensive health behavior and lifestyle treatment. So children as young as 8 could be potentially treated with pharmaceuticals. Now, these pharmaceuticals are not for every child. They're not for children unless they have very high body fat or very high BMI levels and have conditions, health conditions as associated or in addition to their body size. These drugs intend to reduce body weight. They're not targeted at improving the conditions that a child might have. They're intended to decrease body weight. Many of the studies supporting this approach are small, they're short-term, and they have a modest effect. Significant side effects exist, mostly of which are GI or gastrointestinal side effects like nausea, diarrhea, that sort of thing, vomiting. And some of the pharmaceutical drugs that they reviewed in this document have bad enough effects that kids literally just drop out of the study because it's too hard to live their lives with these side effects. But most importantly, when you look at the use of pharmaceuticals in children, the long-term efficacy is missing. In other words, we need more proof that this is an effective way to help children. Remember, helping, not harming. And I don't feel like there's enough long-term evidence here to say that pharmaceuticals are effective long-term for children. Now, I might be proven wrong, but let's bring on the science. Let's see kids 20 years out with pharmaceutical treatment and then make decisions that these things are safe for them. And then fifthly, another aggressive form of treatment is surgery for children 13 years and over. Again, these children are identified as having very high body fat and health conditions. And the surgery is a bariatric surgery, typically a Roux-en-Y surgery where the digestive system is rerouted to encourage less absorption and minimizing the amount of food that children can eat. There's not enough compelling research here, in my opinion, and there's not enough long-term follow-up. These surgeries produce lifetime body and digestive changes, and they can happen, obviously, as young as 13 years of age. So a family really needs to be very knowledgeable and very aware of the risks and the potential long-term effects of this intervention. Some of the studies show weight regain after these procedures, and several studies show significant nutrient deficiencies as a result of surgery. Several studies highlight that children have to come back for additional surgeries after the primary surgery due to complications. So this is not something to take lightly. It's something that should be very considered amongst families with their healthcare provider. So I think when we talk about these guidelines and, whether they're effective or whether pediatricians will actually implement them, I'm all for lifestyle behavior improvement. I think it helps every child, but I'm also all for being very, very, very conscious of stigmatization and taking a non-stigma approach. And I think you have to do that by being weight neutral. So the focus should be on the health conditions that children might be challenged by, not their body weight. So this weight-centric approach, where we use one measure, a BMI, to trigger treatment, feels wrong to me. It doesn't feel like it's addressing the whole child. It doesn't feel like it's balancing well enough the physical health and emotional well-being of the child. And it's not focused on health conditions enough. So that's where my disappointment really lies. It's a missed opportunity to change healthcare, to change the system, to change stigma and bias about bodies, and increase acceptance of diverse bodies. I think it's important for all of us to remember, and especially if you're a pediatric healthcare provider who listens to this podcast, get your hands on these guidelines and read them for yourself. It's important that we remember we're here to help, not harm. There are many great pediatricians out there who don't go this route. They really do try to help and converse and understand and not stigmatize families or their children. I'm curious to see who out there will actually follow these guidelines, whether they will really take hold, because we're all in the profession of helping children to advocate for their health and their well-being. And I don't feel like we spend enough time thinking about or talking about children's emotional well-being. Weight is not a behavior, and we need to keep our eyes on behaviors that can be targeted. And weight is not necessarily a medical condition. There are many people who live in larger bodies who are perfectly healthy. And there are many individuals who live in smaller bodies or mid-sized bodies who are not healthy. Size doesn't matter. It's the health, the physical functioning of the body that we should be focused on. So now those are my disappointments. And I just thought I would just tick off some of the concerns, the ongoing concerns I have related to these guidelines. One, autonomy. In the end, individuals have autonomy to make the decisions that are right for them. Families have the autonomy to make the decisions that are right for their children. But many families I know will follow the advice of their doctor. And if their doctor is prescribing drugs and surgery, my concern and my hope is that these families are fully informed, really appreciate the impact, and also understand that their child is sort of a passenger on the train. That child does not have the autonomy necessarily to make those decisions. Now, interestingly, a couple of years ago on my podcast, I interviewed a young woman who did have bariatric surgery, and it went very well for her. And if you're interested in listening to that, that would be episode number 109 if you want to listen into that. Remember, drugs, pharmaceuticals, and bariatric surgery can have lifelong implications, and some of them are irreversible. So this is not something that and I don't think pediatricians are going to be just tossing this out as the go-to treatment, but these are things that we need to keep in mind, and I worry about for children. I really do. Another concern I have is abuse. I was just talking to a physician friend of mine who mentioned that a sorority girl asked for a prescription for Ozempic before a weekend dance. She wanted to use it for a quick solution for weight loss. This is the abuse I worry about. I hear about adults and celebrities who do not have the need for these pharmaceuticals, getting them and using them inappropriately. So what makes us think that families might not feel desperate or might not abuse these as well? I worry about that. Stigma is another ongoing concern for me. Perpetuating stigma. Again, those individuals who might live in larger bodies but have no health problems. Do we really need to problematize this? And what about children who have higher body weights or who live in larger bodies and do have health problems? We need to focus on treating the health problem. Access is another concern of mine. Many of these recommendations are out of reach for the families who might need them the most. And if you think weight loss cures the health problems, perhaps that might be true. But what is also true is that weight loss is very hard, difficult to sustain, and oftentimes results in weight cycling, that lose weight, gain weight, lose weight, gain weight, that is far more damaging to the metabolism. So what's the emotional cost to all of this? Again, poor mental health, low self-esteem, self-hate, unworthiness, and a perpetuation of the cycle of shame and stigma. So there you have it, my friends. Those are my thoughts on the latest American Academy of Pediatrics clinical practice guidelines for children who live in larger bodies. I'm curious about what you've heard about these and how you're feeling about them. You can let me know over on my Instagram page, the.nourished.child, or i.am.pdrd, or you can always shoot me an email, jill@jillcastle.com, or jump on my Facebook page, The Nourished Child, and let me know. I hope you are all well, and I'll talk to you next time. Wherever your child is, make sure you give them a loving squeeze today. Bye for now.
Thanks for listening to the Nourished Child Podcast, where the #1 goal is to help you grow a nourished child inside and out.